Tysabri is the most important driver of stock valuation for Biogen IDEC. It is currently the second largest revenue drug at almost $2 billion per year. However, the drug is very controversial amongst clinicians, patients, and investors because it causes a deadly adverse event called PML. The JC virus, which lies dormant in most people, is allowed to flare up and attack brain tissue in people when the immune system is depressed by Tysabri. Tysabri has other negatives in that it is very expensive for patients at more than $26,000 per year and also requires monthly visits to the hospital for IV infusions. Soon to be approved by the FDA is another MS drug by Biogen IDEC called BG-12. It is an easy-to-take oral pill and has a proven safety record being used by dermatologists to treat psoriasis for decades. BG-12 will be used either in first-line therapy or possibly as a new second-line therapy instead of Tysabri. Whether BG-12 will cannibalize revenue from Tysabri is something that Wall Street analysts are downplaying. To investigate this risk of BG-12 cannibalizing Tysabri, we interviewed Dr. Barbara Geiser, who heads the MS Center at UCLA.
I'm Barbara Geiser. I'm the clinical director of the multiple sclerosis program at the David Geffen UCLA School of Medicine in the Department of Neurology. The story is apparently it had been used as a desiccant and a fungicide when they were shipping furniture, and they were noticing that people would sit on these furniture and get rashes and skin problems. The story is that a neurologist and a dermatologist happened to run into each other, and they had a conversation, and the neurologist said, "Hey, I've got a couple of my patients who happen to have MS and psoriasis, and they've been getting this drug, which is called Fumiderm, and their MS got better." And so this may be an apocryphal story, but based on that observation, they started doing trials with this agent, which had been approved for psoriasis for people with MS. We actually have currently 9 FDA-approved disease-modifying therapies for multiple sclerosis. And the first one of these, beta-seron, which is a brand of beta-interferon, was approved almost 20 years ago. Next spring it'll be 20 years. So what we call our platform disease-modifying therapies are the different brands of interferon and a non-interferon called Copaxone. And these are all indicated primarily for use in relapsing remitting disease, and these are the drugs that usually most people get started on when they're newly diagnosed. We have a chemotherapy agent called mitoxantrone, which is generally reserved for progressive disease or disease that's not responding to the other agents. We have Tysabri, which was introduced, I guess, about 8 years ago now. Which is an infusion. The platform agents are injectables. And over the past 2 years, we've had 2 oral agents introduced. The first oral agent was called Gilenya, was introduced just 2 years ago, and a brand new one that was introduced last month called Aubagio. And these agents have different efficacies and different side effects profiles. With the interferons or with Copaxone, you have to inject fairly frequently, ranging from once a week to every day. With an infusion such as Tysabri, it's once a month. The oral agents, of course, are oral. And what happens is that some of the newer agents are more effective against placebo at preventing relapses than our older agents, but as is often the case with medication, with greater efficacy comes a somewhat greater side effect profile. Tysabri probably has, we have the most information about this. It turns out that in people who harbor an agent called JC virus, and about 70% of us do, in people who are JC virus positive with prolonged use of Tysabri, and if they have received prior immunosuppressant agents, they are at risk of developing a rare and very serious brain infection called PML. Since the beginning of the year, we've had a very sensitive and reliable test for the JC virus, and so in people who are JC virus negative and who have not received immunosuppression, the risks of developing PML with Tysabri are fairly small, but they're still a concern. So when I see a newly diagnosed patient, I will put them on one of the interferons or glatiramer or Copaxone. And then it kind of, if we have to, we will switch an agent either for lack of tolerability, which only happens about 10% of the time, or failure to respond. So what I will do is, if they're on an interferon and not doing well, I will most likely switch them to Copaxone, or vice versa. But of course, now we have the option of putting them on Gilenya, which is a very effective anti-inflammatory agent. And as I get a little more comfortable with that drug, I may do that. What we also sometimes do with people with unstable disease, or particularly with people with progressive disease, because these agents have not, especially the newer agents, have not been shown to have efficacy in progressive disease, I will do an off-label chemotherapy use. And that's sort of an older practice, and one that I'm a little more familiar with. One of the side effects that's very well known with Gilenya is that it causes bradycardia, a slow heart rate, and so that's why the first dose has to be given in a monitored setting, and pulse and blood pressure have to be monitored. What occurred were a handful of fatalities that appeared to be drug-related in people with pre-existing cardiac conditions on cardiac medication. So I think what we're learning is people with cardiac conditions on cardiac medications is a contraindication to using this agent, and they've tightened the monitoring a little bit for the monitoring requirements. Most people with MS are young, otherwise healthy people, and so I think for the vast majority of people with MS, this shouldn't be a concern. I personally don't use Tysabri. I have very few patients that I will put them on. Not only because of the concerns of the PML, although as I say, you can certainly stratify that risk, but also there's some data that suggests that some patients may have a rebound syndrome, and I'm just less comfortable with this agent. I think initially I would most likely put somebody on BG-12 who is not doing well on an interferon or a Copaxone. Although as I get a little more comfortable with it, I can anticipate using it as a first-line agent instead of the older drugs. I think it might be an option. I think what we don't know is what if there is going to be any potential interaction between people on Tysabri then switching to another immunomodulatory agent. It may not be a concern, but I think we have to consider the possibility. There have been some reports of people who stopped Tysabri and then had a very aggressive attack of MS. Again, this is not very widespread, but it does occur. Or it may just be, again, that the disease had been so successfully suppressed by the Tysabri that when the agent is stopped, the disease comes back. As I say, I do not use a lot of Tysabri, but I certainly hear from colleagues who do, and most of what I hear is that it is a very effective agent, and when properly monitored, a reasonably safe agent. Absolutely, absolutely. In the two studies that were recently reported in the New England Journal last month, the primary endpoint was a clinical one. It was proportion of patients who relapsed and annualized relapse rate. And in most clinical trials of agents for relapsing remitting MS, that is the primary endpoint. The LMR measures are important, but they're secondary endpoints. So compared to placebo, BG-12, and it varies a little bit with the dose because they tested twice a day and 3 times a day dosing, but the reduction in proportion of patients who relapsed was around 50% depending on the dose, and the reduction in the annualized relapse compared to placebo was around 45%. And if you look at the effect of interferon or glatiramer on relapse rate compared to placebo, it's around 33%. Well, I think the big advantage that BG-12 has over some of the other agents is, again, it's been used in a slightly different population and at somewhat different dosing, for about 15 to 20 years. And my understanding is there's almost 110,000 years of patient experience with this agent, again, not in an MS population, but in another autoimmune disease. And so given that patient years experience, I think if it were to have a very serious or long-term side effect, we probably would have seen it by now. So I think that's something that gives BG-12, were it to be approved, an advantage over a newer agent that we only have the several years clinical trial experience. And that's why I'm potentially more excited about it.